All right. Hello and welcome back. I'm Eric Sunset, the host of the Doc Buddy Journal. Here at Doc Buddy, we deliver healthcare solutions that take the pain and cost out of broken workflows, like with OpNote, which gives ASCs and their affiliated clinics the power of instantly generated operative reports. You can learn more about that and all of our solutions at docbuddy.com. And we're kicking off 2025 with a really cool guest. Today, we're joined by Dr. Alex Zusman. Dr. Zusman is Chief Medical Officer at the Clinician, where he oversees medical governance, develops clinical policies, and collaborates with product teams to ensure safety and compliance. He's also a board certified pediatrician who's provided care at UCSF, Benioff Children's Hospitals, Muir Health, and Kaiser Permanente. Dr. Zusman, thanks so much for joining us today.
Thanks, Eric. It's great to be here. It's a pleasure to be able to talk about things that I love with your members and your audience.
And it's notable for some that we are closer than ever a podcast guest, and the host of the show have been you're in Miami as well, just across town. So glad to have you in Miami-Dade County. But before we get into our show today, what else should listeners know about you and your work at the Clinician?
Sure. So my role in the Clinician, as you mentioned, is a chief medical officer, and I like to think of myself as standing at the intersection of the product and the customer. I like to add a clinical perspective to what most oftentimes ends up being a really technological conversation. Our customers and our clients tend to have clinical questions. They're seeking a clinical solution. They have a problem in their hospital, in their patient workflows, possibly in their surgery centers, and we're looking to meet them exactly where they are. And so adding a clinical perspective to the things that come up is kind of where I see myself in my role. I've spent over 20 years in the clinical setting providing direct patient care, and I've also been involved with quite a few quality improvement measures at the departmental level, also at hospital level. And now I have an opportunity to kind of flex into a technological space where we get to use digital health tools. We get to leverage this technology to do bigger projects, to solve bigger problems. We're looking at regional public health, population health kind of situations. And so it's a real challenge, but I welcome that, and it's exciting. One of the main areas of focus for our work at the Clinician, which is the company that I work for, we're based in New Zealand, in Auckland, and we are experts at PROMs, which many people don't know about, but PROMs stands for Patient-Reported Outcome Measures. PROMs can be thought of as directly accessing the patient voice. And so traditionally, a patient and a provider will interact in a clinic or in a hospital or in a pre-op area, and there'll be the interactions, and there'll probably be some notes, and there'll be documentation. These days it can be found in an EHR. And that tends to be where the interaction stops. And so it will only be picked up again when a patient and a provider come back into contact. And so there is a space in between the visits that is kind of open. We at the Clinician have been working very hard to develop ways to access that space and to engage patients directly when they are not in the clinic. This is something that we're really good at, and we have a technological platform which enables providers to hear the patient voice when the patient isn't there. So this is a very powerful tool that can be used in a variety of different settings.
Well, yeah, and that's sometimes a very big blank space between either episodes of care or visits into the clinic. A lot of great reasons to have that interaction, whether that's something related to value-based care, potentially even practice marketing. And certainly don't want to put words into your mouth. But before we started to record, I really liked the phrase that you spun. There's a situation unfolding for ASCs around PROMs that nobody's really talking about. And that's what we're here to dive into today. Can you give us a rundown on this situation?
Yeah. I mean, ASCs are a pivotal, component of our healthcare system. And over the last decade or two, they have been absorbing more and more of patient care responsibilities. A lot of inpatient work that was previously inpatient is now shifting over to ASCs. And so the burden of delivering that care, and specifically the burden of delivering that care at a high quality, is now being placed on the shoulders of ASCs. Now, ASCs have to be equipped to handle this new burden. And so, when we're talking specifically about PROMs, you mentioned value based care. PROMs are a very important tool in the value based care toolkit, if you will. And this is not new. PROMs are a tool. They've been collecting patient data and using that to assess quality for a while. What's new, as of especially for 2025, is that CMS is now beginning to utilize PROMs in a way that they've never utilized PROMs in the past, specifically for patient care and uh, ensuring the highest quality of care. And what I mean by that is that for the first time ever, CMS is relying on the patient voice, which is transmitted via a PROM or an instrument or a survey, to actually develop quality improvement programs. And the capstone or the flagship program that CMS has been rolling out now is called the TKA PRO-PM. And THA is total hip arthroplasty, and TKA is total knee arthroplasty. PRO-PM stands for patient reported outcome. PM is performance measure. And so, what CMS is doing with this is fascinating. And they are using the patient voice, and they are conditioning the payments to ASCs, payments to hospitals and providers based on what patients are reporting. Now, you may think traditionally quality measures were things like, did you get a bloodstream infection? Were you admitted to the ICU? Did you get readmitted within 30 days? These are these kind of objective measures that you can generally pull off of an EMR or a hospital administration kind of record. What hasn't been ever used before is, can this patient go up the stairs now? How would this patient rate their back pain or their knee pain, or can they play with their grandkids, for example? And so CMS is actually going directly to the patient and asking the patient about their quality, about how they feel, about how they're doing post surgery, and then CMS is saying, if they're doing well and you're asking enough patients, you will get your financial payments. And in addition to that, they're also going to be adding this level of transparency, which is fascinating because they will be publicly reporting the results of these quality measures so that the public can see what surgery center is doing and how they're performing and compare it to the one down the road. So people will begin to vote with their feet. And so this is really going to hold ASCs. This is going to hold their feet to the fire, I think. So there's going to be quite a bit of work ahead, among other things that we can discuss, that's going to be landing on the plate of the ASC administrators and providers.
Well, like we said, this is a situation unfolding that hasn't gotten a lot of attention yet, and I know we're going to talk about that. We have many clients at the ASC, administrators, surgeons. They want the very, very best outcomes for their patients. That's why they do it, obviously. That's why they are doctors, surgeons, and whether they're choosing to work in the ASC, you have that triple aim of healthcare all aligned. So then you have CMS bringing this news down that, by the way, we know you do good work. We see the cost data, we see the outcomes data. You're getting as good or possibly even better care at the ASC than at an HOPD, and that's not really up for debate. There's data around that. But by the way, we're going to insert ourselves into this process when the patient's not in front of you, by the way, and we're going to be collecting that data, scoring you on it, and reimbursing you based on it. This is already happening to some extent in the inpatient setting, if I'm not mistaken. What's the reaction been there to this? Because as a lifelong health IT guy, I can't imagine too many providers are all that thrilled
No,
about this development.
no, I think no one's no one's thrilled with more regulations and more mandates. And as you said, this is now live and mandated for the inpatient setting. So any knees and hips that are being done in the inpatient setting in the Medicare population, there's some other eligibility criteria. These cases need to be reported on right now, and there are financial penalties if you don't report on enough patients. And as I mentioned, there's going to be public reporting of the results. At the moment, ASCs are under, or outpatient procedures are under they're in the voluntary period, which means that they're being encouraged to collect data, analyze the data, and report the data back to CMS. But at the moment, CMS is not publicly reporting the data, and there are no financial penalties. You can think of this voluntary period as kind of a dry run. And in the inpatient experience, the hospitals that participated fully in the voluntary period are the ones that are doing the best right now in terms of collecting the data and reporting the data back to CMS. Because as you can imagine, this is going to entail a certain amount of infrastructure. If you think about the small and the medium-sized ASCs out there, maybe they don't have all the infrastructure that maybe the larger ASCs or the larger ASCs, national ASC, regional ASC networks already have in place. Maybe they don't have dedicated staff. Maybe they don't have the tech tools, the digital health tools to collect that data and to report it. So it's quite a bit of burden, especially on the small and the middle-sized players. But in the hospital, the people who got a jump on it, the people who got a head start, they were able to build up their workflows. They were able to assign their tasks. They were able to make all the mistakes, frankly, okay, before it counted. And so right now, the ASCs are in this kind of unique period. They're being asked to collect data, and so that they could basically get their workflows up and running. Now, if you're in the ASC world, you know that on January 1st, 2025, OAS caps also went into mandatory effect. And again, this is a patient experience measure, a little different than outcome measure. This is a patient experience measure, which is also going to be integrated shortly, imminently, I guess, into the ASCQR. And so, I'm not going to mince words. I think the ASCs are getting hammered right now. They're getting hammered with regulations. They're getting hammered with mandates. And as the burden mounts, you are hearing people complain. It's not fair. It's too much too soon. We don't have EHR integration. We need to test this a little bit more. And I think that, I'm a provider. And I think at the end of the day, I keep in mind that what is the most important thing here is the quality of the care. I mean, what are we doing for our patients, right? And it's good for business too. You want to be the best. Think about this as an opportunity. You're going to be getting publicly reported on. This is an opportunity to shine. You want to be the best in your region, in your neighborhood, in your state, or wherever, so that people flock to you for the procedures. I mean, this is what we want, right? Business. But you also want to be providing patients with the best care possible. So CMS is pushing ASCs in this way. They're pushing them in this direction. And of course, they're going to have to go. But at the moment, it feels like they're going kind of kicking and screaming. And sure, I get it. This is going to cost money. People are going to have to figure it out, right? And so what ends up happening is this new challenge is begging for solutions, right? And this is kind of what we're working on right now at the Clinician.
Well, I want to talk a little bit about EHR. You referenced EHR a couple of times, and there's certainly some amount of parallel back to meaningful use. Not completely the same. I mean, it is very different, but still kind of CMS putting their foot down and saying, no, this is how it's going to be, or else. But this is all reporting that, to my knowledge, isn't something that the leading ASC EHRs have functionality around. Surveying, collecting surveys, and then being able to report on the results of those surveys. I don't believe that's functionality that currently exists.
You're correct.
And depending on who you ask, Depending on who you ask, there's some amount of penetration of EHRs into ASCs. They all have a PM, they all have a practice management
Yeah,
system. Not all of them have an EHR, and that
yeah,
penetration rate will vary, but this is something separate and distinct.
yeah. Totally separate and distinct. And like I said, this is the first time CMS is doing it. So there really hasn't been a need. Well, welcome to 2025. And I think that if you look at the CMS language, what's coming out of CMS Innovation Center, and this all started with the ACA back in 2010, there's a pipeline of pro-PMs coming. This is now a thing. This is now a functionality that all providers, not just ASCs, not just orthopedics, are going to have to figure out. Patient-reported outcome measures are going to just become part of the daily what you need to do. It's also part of providing good care and good patient engagement. Just always keeping the patient in mind here. But when you bring up EHRs and the functionality of EHRs, absolutely, they're very limited in this respect. And what we've learned kind of as we kind of are developing some products and learning about this space is that the EHRs will respond and they will begin to incorporate this functionality, but only when people start asking for it. And so what's interesting though is in all of my conversations with possible customers or clients who are looking for solutions to address this the CMS mandates, one of the first questions they ask is, "Do you integrate with my EHR?" I feel like this has somehow been conditioned into. Let's see, we got some sun on my face. There we go. I feel like this has been conditioned into everyone's dialogue, where it's something. There's almost like this belief that integration into the EHR is a good thing. It makes your life easier. It makes your life more simple. It provides you with a better or more robust data experience. But actually, it's it takes a very long time to implement. You have to do leaps and jumps and all the hoops to meet all the compliance and security regulations. And as you can imagine, every hospital has their own, every clinic has their own. Um,
Alex, I don't have to imagine, by the way. I just want that on the record.
it's expensive. Okay, it's expensive. It costs more, and it's prone to problems. Right? I mean, you have multiple moving parts with EMR integrations, and so um, I feel like this is the kind of like the old way of doing things, where we sit down, we get an integration specialist, and we bring them in, and we start creating APIs, and we start linking into these large the Cerners and the Epics and the all scripts of the world. And sure, it's very slick and it's definitely doable. But I'm thinking about the future here, Eric, and I'm thinking about more and more pro PMs coming down the pipe. And I'm thinking about the burden. And I'm thinking that as things get stacked on the shoulders of not just ASCs, but hospitals and providers across the board from regulatory bodies like CMS, the need to have a simplified solution, okay, becomes more and more imperative. And what I mean by simplified is the need to have a solution which is almost independent from the EMR. It becomes more and more relevant. And so this may be a controversial point, but when we talk about how we would like to position ourselves to solve these mandate challenges, we're actually focused on solutions which are detached from the EMR. We're actually looking at non-integration kind of solutions. And one of the things that we've been trying to pivot toward is the SaaS model. And the enterprise model, is creating a solution is very laborious. It's expensive. It takes time, and it's customized. And they're beautiful. I mean, things that we've created, we're very proud of. But think about the small and the middle-sized ASCs and the small and the middle-sized providers out there. They may not have budget for a customized solution. They may not have time for a customized solution. They may not even have an EMR, because I know there's a pretty low EMR uptake in some of the smaller middle-sized ASCs and providers. Maybe they have, like you said, practice management software. And so I feel like if we position ourselves to create a SaaS solution, which is EMR free, we actually position ourselves to create a very efficient and easy to implement solution. And and part of that is also cost effective, because the price tag on these SaaS solutions are a fraction of what the price tag on these enterprise solutions are. And so if you're an ASC administrator, or if you're out there trying to figure out what the heck to do with THA, TKA, maybe you're not familiar with SaaS solutions. Maybe you're, you really are committed to integrating with an EMR. I would just challenge that thought. I would just say, what about doing something that's quick and easy? I like to think of it as the TurboTax uh, of proms, or CMS mandates. Before, you used to go to an accountant, spend a lot of money, takes a lot of time to file your taxes. These days, most people can probably download TurboTax for $40 and probably finish your taxes in a week. And so I like to think of us as kind of moving toward a TurboTax model for these kind of solutions. And that's kind of what I wanted to put forth, because when we talk about EMRs, they lack the functionality. They may or may not rise up to this level, but in the end, we're trying to pivot away from the EMRs, I think.
That makes a lot of sense, and I mean, I see your side of it just as well as I could see the conditioned response of, oh, it's got to be integrated. But that really only saves you the time of entering in a patient name and I assume email to distribute the survey.
Exactly.
So how much time are we really talking about
Yeah.
here? Not very much. And you go a step further, you mentioned it's not necessarily every patient that had a THA or a TKA. It's potentially a subset, or you only need to submit a subset of responses. I would imagine there's a little bit of don't take me out of context. I know you won't, but listeners, don't take me out of context. I would imagine there's some amount of gamesmanship there where, somebody who is not well to begin with has this procedure performed. That's not going to reflect well on you because they're nearly at death's door to begin with. Whereas most of my panel that had these procedures performed is doing great.
It's
I
interesting.
mean,
Interesting you bring that point up. CMS has a recipe, and they have eligibility criteria, and it's going to be very hard to cherry pick your patients
okay.
for this specific mandate. Now, other pro-PMs, other CMS programs, maybe so. This one, they have eligibility criteria, and they have some strict reporting criteria. And if you don't report on the mandated number of patients, you will get hit with a financial penalty. So I think providers and ACs have to be very careful about how they want to approach this. You know, because there's a recipe, there's very little customizations. Your providers can't come in and be like, I'd like to do this, but not that. CMS will have none of it. And because at the end of the day, all the data that you collect on all the eligible patients need to be reported. And another piece of the solution that we're working on is facilitating this reporting function. If you can imagine, what CMS is asking people to do is engage with patients before their surgery and after their surgery, collect data from before the surgery and after the surgery. I just want to point out that the time points are over a year apart. And so you're asking an ASC to engage with a patient over this extremely long period of time. This is an administrative challenge. It's a very difficult thing to accomplish, especially with ASCs that sometimes only interact with patients for a limited number of hours, really, or during their procedure, or with their providers. It's a one and done. And so, again, the lack of customization favors this SaaS approach to the solution. This is not something that we're going to sit around and discuss about what elements of the medical record we want to include or not. It's prescribed. It's just set. And so it's an off-the-shelf kind of an experience. And that's what we're leveraging to create a digital health solution that will streamline workflow, right? That's the whole point here. Create some efficiencies, create some cost effectiveness. We really believe that, especially the TKA PRO-PM is ripe for this kind of a solution.
Well, I certainly didn't mean to suggest any sort of gamesmanship or cherry picking, but it sounds like there's even less to think about since that's an
Correct.
impossibility. It has to be really highly systematized, and then the burden of this really falls to the patient because on the facility side or on the hospital side or the practice side, whatever it may be, you load up the hopper with email addresses, the surveys go out, and then we wait. But I think about how many survey emails I get. How did we do? How did we
Yep.
do? And guess what happens to virtually 99% of virtually all of them?
Yep.
They just go straight to the trash. So, what do you do as a facility to guarantee, maybe not guarantee a response, but what can you do to elicit any type of
Well,
activity?
you want to stack the deck in your favor. And of course, CMS will allow you to do this in any way, shape, or form. You can do it on the phone, and you're going to have people phone calling before or after. You can do this through your EMR portal if it has that functionality. You can do this in any way. CMS will allow you to collect the data in any way, but you should stack the deck. And to address the issue that you raise, which is basically, response rates, what we call response rate, is you want to have a good, reliable, and effective patient engagement tool. And this is where leveraging digital health solutions really comes into play. If you have something that can reach your patient effectively, it makes it easy for them to answer these surveys, which, like you said, 99% of the time gets deleted, go in your spam folder. You get something in the mail, you don't know what it is, and it gets chucked with the rest of it. You really need something that's going to engage the patient. And like I said earlier, can you imagine engaging a patient a year after the surgery? They may be like, what are these people even asking me about? And so our idea here is that we create a relationship with the patient over time. It starts before the surgery and carries uh, through the post-op period, and we're able to engage patients while we're developing our tools right now around THA and TKA. Our response rates for our other products has been upwards to 70 to 80% response rates. And it's important to mention that the financial penalties that CMS will enact are based on the response rates. And so you can be an awesome surgeon and get an AASC and get great results, and every one of your patients are happy, but you're not collecting enough surveys, you're going to get dinged. And the ding is significant. For inpatient, it's 25% of your annual payment update. And for ASCs, it's going to be 2%. But with ASCs, there's really going to be no way around this reporting requirement, because not only are they requiring it for the knees and hips, but they're bringing this into the ASC QR in 2025 or 2026. The ASC 21 is going to be the newest addition to the litany of ASC QR um, uh, data points that need to be collected. I mean, and I think if you speak to any ASC, they'll be pulling their hair out with what they need to deal with to meet all the ASCQR requirements. Um, OAS caps on top of that. Again, the burdens that are mounting, they're begging for a simple, efficient, and cost-effective solution.
Well, this is kind of the other foot or the other shoe dropping, I guess. All these procedures coming off the inpatient only list out to being eligible to be performed at the ASC. It's a little give and take from CMS there. Some prior guests have suggested, and I happen to agree to an extent, that an EHR mandate is probably not too far away, unless they can get all the data they want out of patient surveys such as this. And that's actually a point of interest for me. How long is a survey? As a patient, they get the survey. Is it a 5 minute bubble in a few answers, or are
Yeah,
we talking like a half
yeah,
hour to think
good
about?
question. Well, so there's two time points. There's the preoperative and the postoperative. The preoperative has more questions. Um, um, uh, the CMS is collecting some extra data to risk stratify. And so this goes back to your comment about how my patients are sicker, so my results are going to be worse. Again, CMS is not penalizing anyone for worse results. They're penalizing people for not collecting data. But they
Hmm.
are collecting some data to risk stratify, so to create a case mix adjustment, so to speak. I think they have their own methodology and their own biostatistical models to do that. You just have to submit the data.
Okay.
But in terms of the surveys themselves, the uh, the the mandate functions on the WHO's Junior for hips and the COO's Junior for knees. These are surveys. These surveys are not lengthy. I'd say on paper you could probably fill one out in about 3 minutes, 3 to 4 minutes. With a digital health solution that shows up on your phone as a text message or as an email that you can click on, you could probably click through in about 1 to 2 minutes, I think.
Okay.
That being said, if you speak Spanish, maybe you get an English survey and you delete it, or you have to find someone to help you translate it, and so that takes a lot longer. There's 100 different obstacles that'll get in the way of between you and filling out a survey, even if it's a minute or two long. But just again to reiterate, these 1 to 2 minute surveys, this is what CMS is using to determine if you get your money and if you can, shine with this public reporting requirement. It's wild. I think it's great. It's a great effort to put quality at the forefront, and in addition, to put the patient's voice at the forefront. But there's quite a bit of figuring out that needs to happen. And so, you know, leveraging digital health solutions in this moment, I think, is going to be the key to any kind of long-term strategy as more and more pro-PMs come out of the pipeline, and also, helping lift yourself up to become one of the best quality providers in your area, in your network, or wherever. It's good for business too.
Yeah, CMS is the ultimate Yelp, as it were. So I'm not sure how much of a policy wonk you are. You mentioned this came about with the ACA 2009, I think, when that was signed into law. What was the end goal? What was the stated goal of collecting all this data? Because I'm sure folks like the American Medical Association lobbied, I would guess, against this, as it's one more thing providers have to do. I'm just guessing there. I don't know that. But why are we going through all this rigmarole to collect patient data? Looking back at time 15 years now.
Yeah, I mean, I think, yeah, going way back, and I'm not a policy wonk, so I don't claim any area of expertise. But what I do understand about the ACA and kind of the climate of 2010 was that it all came back down to value-based care, and Dr. Porter and the value-based care kind of ethos is essentially creating the highest quality care for the lowest price, the lowest cost. And so these are the driving principles of the ACA. Is just, again, delivering the highest quality care at the lowest cost. And so how do you do this? There's a variety of different, I think, practices that were implemented at that time. They all were kind of spinning out of the CMS Innovation Center. Other programs which you may or may not have heard of are accountable care organizations like ACOs. Um,
Of
that
course.
came out of the CMS Innovation Center and the ACA. Merit-based incentive payment system, the MIPS, came out of that too as well. These are all, again, quality measures to increase quality, drive down costs. The prioritization on quality metrics, patient satisfaction, care coordination is these are priorities. Now here we are 15 years later, and they're now implementing programs. I mean, that's the snail's pace, I think, that we work on. Um, there's quite a few pro-PMs that are coming out and through the pipeline, which are going to be really focused on care coordination, leaving the hospital, coordinating with your primary care provider. There's going to be lots of financial incentives for people to work on that care coordination piece. And so, not a policy wonk, but my impression of the ACA was we need to up the care, up the quality, and drive down the costs. And you know, programs like the TKA Pro-PM, that's what they're gunning to do. Okay, now doesn't mean it's easy. Doesn't mean it's not going to cost money. Doesn't mean it's going to create headaches. What I would say is can't bury our heads in the sand. You know, I know we have a new administration coming in. I've heard people say maybe this is all going to vanish. I don't know. I think that's a little unrealistic. You can't just delete these things as quick, these types of things as quickly. But I think it's inevitable. I think it's inevitable. And what I would suggest is that we pivot away from kind of throwing our hands up in the air and just crying foul, and we support our providers and our ASCs by giving them the best tools to get the job done, the best tools to avoid financial penalties, and the best tools, like I said, at the end of the day, to elevate the quality of the care being delivered to the patients. And at least for ASCs, inpatients already in the mandatory phase, but at least for ASCs, the time to start is now. We're in the voluntary period. There are no penalties. There's no public reporting right now. There's a great opportunity right now. Let's create some efficient workflows. Let's explore digital health tools, and get the compliance dialed in, before it becomes mandatory and everyone's going around crazy trying to figure something out, last minute.
Yeah, now's the chance for the running start, and I need to editorialize for a second. Misspoke. I referenced the ARRA, which included the High Tech Act, so often. That's 2009. You're spot on. ACA is 2010, and you also mentioned a dog whistle for me, which is MIPS, the successful to meaningful use. And you're the exact right guy to ask about this. That a long time ago was in the practice EHR space. We have pediatric offices wondering why on earth they're asking 5-year-olds their smoking status. Yes. That's a dumb question. Now, obviously, pediatricians treat patients all the way through to 18, and they might have some smokers on their panel. So I'm not saying it's an outright bad measure. What you're describing with pro-PM, though, seems a little more thoughtful than asking, little Susie, how many packs a day do you smoke? What's your take on that?
Well, I mean, I'm a pediatrician, and I've encountered a lot of, in pediatrics we say the kids are not just little adults, right? They're kids, and so yeah, there needs to be pediatric specific stuff, and yeah, they've kind of messed things up, I think, from time to time. Eric, can you repeat your question again? I missed that last part of it there. I got into the pediatrics piece.
Yeah, it was bait for you. It was too juicy to pass up. But when you look at these older measures around meaningful use and MIPS, and that's the example that comes to mind for me asking a 5-year-old child if they smoke or not. Hopefully the answer is always no. I would imagine there's an exception to that. But when you look at that as a mandated quality measure to ensure you retain the integrity of your Medicare payments versus what we're talking about with pro-PMs for THA and TKA, it seems a little more thoughtful.
Oh, yeah, for sure. And it's interesting because as I've been diving into this pretty deep, I've always been struck by the fact that we're just talking about orthopedics right now. And, I think orthopedics are an easy target. Even before this came out, it's very interesting. Michigan has a program very similar to this called Marquee. And they have been collecting state level data in this way. And so orthopedics, and so my point in bringing that up is to say that these procedures are have been worked on from a quality point of view now for quite a while. Also, these are somewhat discrete events. You get a knee, and we're done with that procedure, as opposed to chronic conditions where you're gonna have this long relationship with a provider. So I think that these are more thought out. I think that there's going to be expansion of pro-PMs from CMS. I think there's going to be more and more patient voice injected into quality improvement measures across the board. Just some examples really quickly, which are not necessarily ASC focused or not necessarily knee and hip focused, but for 2025, it's going to be a big year. There's going to be TEAM, which is transforming episodes accountability model. This is going to take 5 different episodes from the inpatient space. It's going to be everything from coronary artery bypass to GI surgeries It's including knee and hip as well, spine. There's one more off the top of my head, I can't remember, but these are going to be about coordination of care. There's going to be GUIDE, which is another program that focuses on dementia. There's going to be Transforming Maternal Health, the TMAH program, and this is going to be focused on maternal health and obstetrics. There's the Information Transfer Pro-PM. This will affect some of the surgical specialties because, again, coordination of care. This is about how they did, I think it's 6 weeks after their surgery, and were they given the right information, post-op care, and the details. There's quite a few of these measures which are coming out. So it's an exciting time for proms in the world. It's an exciting time to be developing solutions to tackle these kind of mandates and these kind of pro-PMs that are coming out of CMS. It's a great time to be a patient because your voice is going to be heard. It's a tough time to be a provider because you're being asked to do more things. So we just need to get smart. We need to get the right tools. Like just like you're building something, you need the right tool to build it. You need the right tool to meet these new requirements.
Well, this is a huge tangent, but would be curious to get your thoughts on this. That I've had many guests on to talk about value-based care, and the one that sticks out most to my mind is Dr. Dan Blumenthal. He's been on the show a couple of times, Chief Medical Officer for CVA USA, so somebody that knows a thing or two about quality care, or value-based care, rather. I'm paraphrasing, so we'll have to point you to the episodes to hear exactly what he said. But in the value-based care programs that he oversees and has helped to launch with CVA USA, some of the challenges he has are around patients being accountable for their own health outcomes. And this is a big discussion, right? Socioeconomic impacts on health. I'm not going down that path specifically. But do you think these proms and these pro-PM requirements are going to be a way to spur patients into taking more interest into their own health outcomes? I mean, the ethos now is I go to the doctor, I get a medicine, and that's kind of it. I take the medicine.
Yeah,
I didn't stop smoking. I didn't stop eating fast food 3 times a day. I mean, that's a big issue, though.
yeah. I think it's really interesting, and I'm sure there's a variety of opinions on this, but I feel like the more involved that a patient is in their care, the more involved the patient is in their care. And I think that what's interesting about proms is that it is changing the paradigm because, the paradigm, I think, and from the old school provider point of view, is that providers talk down to patients. They have all the knowledge, they have all the information, they come up with a plan, and they transmit that to the patient. They create the bridge over the information gap, the knowledge gap between a patient and provider. But now we're getting the patient's voice, and the patient's voice begins to matter. And so, for example, I'm sure you could envision a situation where a patient would go to see a provider for follow-up every 6 months for a condition, or maybe every year. And between those visits, the patient voice wasn't really being heard. So maybe they had a horrible time during that interval, but no one accessed that patient voice. Now we have a way and we have an interest in collecting that patient voice. And so it gives the patient a level of empowerment, of an individual empowering of the patient to be involved in their health. And I think that can only benefit the patient. Like I said, this is for value-based care. This is supposed to increase the level of quality of care. It's going to raise an alert when there's a problem. And so whereas patients may have been going to the ER to deal with their problems in between, set visits, now a provider might actually say, hey, we got the survey back from a patient because we're on this pro-PM, or because we as a provider group have created a quality improvement program which leverages proms. They're having an issue. Let's bring them in. Let's be proactive about it, and let's get in front of this. This is preventative health. This is public health. You do this on a large scale, and then you're doing population health, right? It could be screening. It could be any level. It also keeps providers accountable because there's benchmarking, okay? And so the traditional benchmarking might be how many surgeries you did, or how many readmissions you had, or how many surgical site infections. Now it might be how's your patient doing? Like, are they happy? Do they have the functionality that your surgery or your treatment was supposed to restore. And I think it's a little morbid, but you may have heard of this. It'd be like, oh, the surgery went really well. It was a success, but the patient died.
Yeah.
So there's two perspectives there, right? And traditionally, it's always been about the provider, where great surgery, everything went great, but the outcome was bad. Now we're getting a little feedback from the patient, and that knowledge gap is actually being bridged by the patient. The patient's voice is now being heard, and it's becoming part of the care. And I think that moment, I don't know if we could be at a tipping point, but bringing the patient's voice to the level of the doctor's voice here is, I think, paradigm shifting. And so, this is what value-based care is trying to do: raise the quality, and at the same time lower the cost. So I do think that this hopefully has great potential to move us into a different space, with quality.
I think you're right. And even though pure patient accountability for their own outcomes is maybe a pipe dream, it does offer the provider at least a chance for an intervention. Hey, we got this response back and there's a problem.
Yeah.
Please reach out and keep them back in.
Yeah, and we have several examples, programs that we've been working on that have flagged patients for early intervention. We have several examples of programs that we worked on where we're doing remote symptom monitoring. There's a really interesting program that we're involved with, which is actually flagging chemotherapy side effects and allowing providers to early intervene on chemotherapy side effects, allowing them to get more chemotherapy. Because the side effects would prevent you from getting the chemotherapy. They say, okay, too many side effects, stop. They're getting more chemotherapy. They're treating the cancers more aggressively. They're saving lives because of that. Fascinating, right? This is all because of a survey that was sent out. So there are lots of potentials for proms in this space and for quality. I think I mentioned benchmarking, where providers, will be measured against one another. This is where you'll look at all the providers in a network, and you have some outliers. Why are you here and everyone else is here? Evidence-based. There's lots of evidence-based standards out there, and so keeping people in their lane and creating systems to ensure quality from benchmarking is, I think, hugely important as well.
Hard to argue with that. And as we get to the end of our block here, you've been so generous with your time. We got to say it one more time. We're in the voluntary period now for ASCs. What do they need to be doing now, and when isn't it voluntary?
So we're in the voluntary period now for ASCs and for outpatient THA, TKA procedures. Right now is a perfect time to be developing your workflows, searching out solutions that are going to work for your systems, building that infrastructure, figuring out how, when CMS starts to collect mandatory data from you, that you have everything in place and you're not scrambling. Look for the solutions that are going to work for you. I encourage everyone to stay open to the idea of SaaS solutions, which are quick, cost-effective, easy to implement, and very very amenable to the TKA PRO-PM, because there's no customization. Now is the time to act, for sure. The mandatory period reporting, I believe, in 2027. It could be crossing over to 2028 for outpatient providers. So there is a little time, but now is the time to act. Definitely would encourage that.
I'll just add to that. All of our clients who were EHR users prior to the beginning of meaningful use had no issue. There were many that bought at the last minute, at the end of a eligible reporting period, lost money. So I totally echo those sentiments. Now is the time to get it sorted out.
Agreed.
And with that, where can listeners connect with you, either on LinkedIn, across the web? Where would you point folks to learn more about you and the Clinician?
Yeah, the Clinician, come to our website, theclinician.com. As I mentioned, we're a value-based care, proms-focused digital health company. that is able and willing and ready to help ASCs and providers with solutions that leverage digital health capability across a variety of different situations. Also, you can find me on LinkedIn, Alex Zusman, Z as in zebra, USMAN, and you can connect with me there.
As always, we'll get those links into the show notes. Alex, really appreciate your time. Thank you for joining us.
Thank you, Eric. It was great to be here, and really appreciate the time.
We got a standing invite to come back. And on behalf of the entire DocBuddy team, I want to thank you for listening. Be sure you're subscribed on Apple Pods, Spotify, and YouTube so you always get the newest episodes of the show. Until next time, I'm your host, Eric. We'll talk to you soon.